Rudvij is going to present a curious case of collaterals.
I'm sorry, but I guess so the boxes are not very well arranged. I guess the PPT from one computer to another. Sorry for that. So I'll be presenting a case of a curious case of collaterals. Just to give you a background, what are collaterals, and in BRVO, where do they originate from and when do they form? So they are nothing but vascular structures that develop from the existing vascular beds. They originate from the capillary bed and they join the obstructed and the non-obstructed vessels. There are three types of collaterals: arterial, arteriovenous, and veno-venular. In BRVO, the collaterals are of veno-venular type, and they generally take from anywhere from several weeks or 6 to 24 months. Now, on clinical evaluation, they appear as tortuous vascular channels which link a blocked vessel with a patent vessel, as we can see over here, and they generally lie in adjacent avascular bed. With this background, I'd like to present a case of a 69-year-old female who just presented to us with a general checkup for a general checkup. She had history of hypertension 10 years back and also had a history of stroke for which an MRI was done. She was a diagnosed case of an optic disc pallor in both eyes since 3 years prior. Now when we see the right eye, the anterior segment had an NS1 grade of cataract. The visual acuity was 20 by 20 and 6. We can see over here that there is some amount of diffuse disc pallor that is noted, and if we see at the arteriovenous crossing, we do see some AV crossing changes. Now when we come to the left eye, we can see over here is there is an optic disc pallor that is noted over here, and if you can see that there are dot and blot hemorrhages which are radiating toward the first AV crossing, suggestive of a branch retinal vein occlusion. But at this moment of time, there was no macular edema. There was the vision was also 20 by 20, and the patient had just come for a general checkup. The patient was requested for systemic evaluation and to review after 2 weeks, and was explained that if in case of there is drop in vision, she would require an anti-VEGF injections. So on 2-week follow-up, we can see that the visual acuity at this moment of time had dropped from 20/20 to 20/30 parts. We can see over here that the number of blot hemorrhages and dot hemorrhages which were there have increased from the last time. And as discussed with the patient prior, she was advised to undergo an intravitreal anti-VEGF injections. No, we had she had actually she had elsewhere consulted in the interim, and she had like a paper of an OCT, so we did not request it in our institute again at that moment, but there was an OCT available at that time. During the course of time, she came many a times to us. In the interim, there were increase in the superficial hemorrhages. There was increase in the dot and blot hemorrhages. As we can see over here, also there the vessel which was patent before has now becoming to sclerosed, and there was presence of macular edema also. Over the course of next 13 months, the macular edema came in and went off with injections. She was appropriately treated for the very same with intravitreal anti-VEGF injections, and she maintained a vision of 20 by 25. To our surprise, on the 26th month visit, an inferotemporal branch retinal vein, which was diagnosed prior, had presented with presence of an superior hard exudates in our patient at the 26 months of follow-up. And we do notice, if we see the fundus photograph, the prior vessel which was over here is now going right up to the superior arcade, crossing the horizontal midline and joining to the above vessels. If we see, there are two such collaterals that are there, and beyond these collaterals, the vein has sclerosed. There was presence of some chronic macular edema seen as the horizontal cyst diameter was more than the vertical cyst diameter. So we had a query in our mind that are these collaterals decompensating to the superior half of the retina and causing a back transfer of the increased venous pressure that we know. To confirm that, and also we thought that whether it is presence of just microaneurysms. So we go ahead and went and fluorescein for this patient, and as we can see over the course of time, we see over here, these are the collateral vessels that they are joining over here in the superficial plexus that we are noting, one over here, one over here, and one over here. But we do see some amount of microaneurysms in and around this, and if we comment on the foveal avascular zone, it is distorted in the inferior, close to 120 degrees. Uh, Over the course of later some period, we can see that both the microvascular abnormalities from the collaterals as well as the microaneurysms both are leaking at this point. And if we notice that that inferotemporal vein beyond the collateral vessel has completely sclerosed, which is evident in the fundus photograph over here. At this moment of time, seeing the OCT characteristic of a chronic cyst and a macular ischemia as seen on our fluorescein angiogram, the patient was observed at this moment. But this raised up very few questions in our mind, that why are these vascular changes in the superior quadrant beyond the horizontal raphe? So it has been shown that collaterals do cross the midline. They generally do not respect the horizontal raphe as compared to a normal retinal vasculature. Another question that popped up was, does these changes reflect the decompensation? However, I could not get an answer in the literature for the very same. And if we see over here, beyond the area of microvascular abnormalities, why are these changes in and around this area where there are no microvascular collaterals? So just a final slide. Uh, Here the OCTA helps us. It is known that the collaterals are more present in the deeper vascular plexuses than the superficial vascular plexus, and an angiogram having its inherent, I would say, some limitation in visualizing the deeper capillary plexuses, and OCTA helps us in this. So to summarize, collaterals can originate from the existing capillary vascular bed. They are of three types: veno-venular, arterio-arteriolar, and arteriovenous, and they are vascular channels that do not leak on FFA, and they can be present in all capillary plexuses but are most abundant in the deeper capillary plexuses. So an OCTA will help us prognosticate these patients, and probably this patient went on to undergo a laser to an avascular retina away from the collaterals, just not to decompensate the superior half also. Thank you.
It was a really very nice, in fact, a very nice picture. I was just wanting, and you answered in the last slide itself, that presence of so much of CNP areas does call for ablating these areas, because you can't watch all the otherwise,
Yes.
increased VEGF load, and they can cause. But these collaterals are known to cross the horizontal raphe,
Yes.
and they are friendly vessels. We should not give laser beyond these vessels, because they are all friendly vessels.
And actually, there is an indication of doing laser in such cases. So much of capillary non-perfusion. So CRVO study, BRVO study states that you should do a prophylactic laser in such cases, not for macular edema, to prevent. Those are all at the junction of vascular and avascular retina. They are all budding neovascularizations. Your anti-VEGFs are preventing them from growing, but if you don't give anti-VEGF for a long period of time, they might start becoming new vessels.